Hi. And so I've had a wide variety of experiences. I've worked in the jail and the prison. I've been out in crisis elements, and so I've kind of been all over in that arena. You want to introduce yourself now?
You will go.
All right. I want to start this off first because I have a friend that's in Deadwood, South Dakota. That's firemen out there, and I hear that you guys like to trade T-shirts, right? Amongst the different divisions. So if you guys ever want to do some T-shirt trading, let's talk afterwards, okay? I just wanted to throw that out because that's what I'm hearing.
Orange shirts.
Got orange shirts. Is that working?
It's not working.
There you go.
Awesome. Next one.
Okay.
Kind of what we want to talk about is how the community and EMS actually access our behavioral health services within the whole valley and kind of the region here along the Wasatch Front. We are every major hospital, you can be referred to us for behavioral health services. You guys, when you go out, you may be interacting with someone that you need to bring into us or into treatment into the ER. It could be any ER. Our objective is to really, we're protecting the patient and from self-harm or other people because they obviously could be violent themselves and it poses a risk to you, family members, other community partners. We're protecting the staff too because at least in our unit, and I'm sure when you guys are out in the field, you're looking out for each other and you're having to make sure that you're safe and your partner's safe. And it's also understanding yourself as a frontline worker, you know, what you're capable of doing and what you're not capable of doing. I've had a lot of people on our floor when we've had to get with a patient that's getting a little escalated, they actually freeze. And so it's understanding yourself and how you're going to respond to that individual that may be psychotic. And then also property damage that can occur, and that could be either out in the community or when you bring them into the ER. How many of you have had an episode in like when you're bringing them into the ER, they start going off and destroying the room or hitting each other because they don't know where they are, they're just not within their right mind a lot, right? So our main thing with behavioral health services within the Mountain Division here is to give access to everyone coming. It could be at LDS Hospital, it could be here at Lone Peak, it could be anywhere along this Wasatch Front going up to Irmac. Our MSTAR, or our ARC, is the Access Response Center. So whenever you're bringing somebody in that is a behavioral health issue, how many of you would stop at this ER or would you go to St. Mark's? Because they don't have a behavioral health clinic here, right? Do they have a behavioral health unit? No. So a lot of people actually bypass coming to this type of ER, even if it's closer. The great thing about MSTAR is that you actually can drop that patient off here. They can come to the ER and be transferred through our MSTAR center that will do an assessment on that individual with while they're in the ER. It's usually a kind of a WebEx or a telehealth type of assessment. And what will happen is that as you bring them in, you're letting that ER staff know what you brought them in for, what the physiological things that are going on, where you found them, who they were interacting with, and then they're going to take that information and give it to the MSTAR staff. They'll do a social work consult, and then we can actually either, if they're not committable or they don't meet that criteria to be in the hospital, they'll let them go, or they'll transfer them to one of our centers. So anybody, if you bring somebody to an ER, they can access Lakeview, they can access St. Mark's, they can place people at the U, they can place people anywhere. So this Access Referral Center really is your friend and our friend to make sure that patients are being transferred to the right location and making sure that all of our openings are available to you. They have a number of people that are helping with that process. They have social workers and nurses. So we're looking at everything psychologically and physiologically with them. We get a lot of different orders. We do higher medical acuity patients on our units, wounds, IVs. We don't detox at St. Mark's, but we definitely medicate to symptoms that they're coming off of. Everybody knows, MSTAR gets to know the units and what type of patient they can hold. St. Mark's doesn't have a PICU. We can't separate out walls if somebody's violent. We can't do that. Whereas Lakeview may have a room that they can kind of cordon off and it separates it from other people. We do have a seclusion room, and that's short term, but it's not. That's more of a temporary 4-hour type of a placement. So MSTAR absolutely has to know who we are and what we're about. The other thing is, do you guys have to worry about insurance? Are you collecting insurance or anything on those individuals that you're bringing in? A little bit, no?
We try to get that information.
You try and get that information, yeah. Part of their role is to make sure they're going to the right organizations and they do the utilization review, the initial one, to make sure that these people are going to, the patients are going to get to the right staff and the right hospitals. We also have a direct admission process that we've been doing at St. Mark's and Lakeview, where if somebody's with a provider out in the community and you're called to that location, they don't have to route through the ER. If that person is just depressed, suicidal, not drugs or alcohol or anything like that, but you have that person that we just need to get into the hospital and be safe, we do have a direct admissions process, and we're getting more and more patients related to that, which is great, because that way it cuts down the traffic going through the ER where people that actually need to be in there can.
Can I ask a question about that?
Yeah.
So for the direct admission process, it still goes through MSTAR. Do you guys get alerted of that if it is a direct admission?
No.
No, they wouldn't know that.
Because I know in the past, at least for us, we have had direct admissions that have had to have EMS transfer, and the patient has then gone through the ER.
Yeah.
So maybe that's something that we can problem solve.
We can talk offline on that, yeah, because if they're transporting a patient that's a behavioral health patient, they may just be bringing them directly there. But that's a different scenario than if they're responding to them on a 911 call.
Well, so this would be through a 911 call.
Yeah. It happens all the time, yeah. So really, we're looking at expanding the access and support. We're leveraging the division and capabilities with all the hospitals. These are all HCA hospitals. We want to make sure that we're following all the regulations when we bring somebody in. And we want to make sure that you guys are actually getting information on what works for particular patients. How many of you have had to give emergent meds on somebody to keep them calm coming in? I'd like to find out what you're using when we go through our, when we go in a little bit longer. Also, identifying the appropriate level of care is important. Not everybody has to be transported or put into a hospital setting, and I think that's why the ARC also helps with that process based on information that you as in EMS is giving to the ER. We want to make sure they're placed right. So, are all of these diagnoses that you've seen, schizophrenia, bipolar, psychosis, personality disorders, and mood disorders? You see that all out there. So when we look at a serious, a SPIMI population, severely and persistently mentally ill, those are the people that are probably not going to be taking their meds on a regular basis. That's probably who you're going to be talking to in the community, and then you throw a little drugs and alcohol on it, and it really can be a difficult situation because they may be having paranoid thoughts and things that are happening. They may be seeing things or hearing things that may not be there. Have you guys experienced that? What's kind of the interaction usually like when you're with them?
Always different.
It is always different. Has anybody heard of trauma-informed care? We'll talk about that in a minute. How do you start interacting with somebody when you're seeing these type of symptoms? Is it, I need to pick you up and I need to transport you and get you to the hospital? Is that your goal when you come up on a scene like that?
Well,
what would it be?
The end goal, but
yeah,
you have to approach the patient. Obviously, if they have trauma that requires them to get to the hospital now, that's more important than how they feel.
Absolutely.
If you have time, then you need to try and make the patient as comfortable as you can before you just kidnap them.
Right. It's building that, it's a therapeutic rapport, because if you can build it when they're paranoid or when they're experiencing things, they may be more apt to go with you without you having to do a bunch of stuff to contain them. So understanding where they are, that's trauma-informed care, what they're experiencing in their family, on the streets, in the apartment, with someone else. It's understanding that whole process when you start to interact with them. Bipolar disorder, has anybody seen a really manic patient? What do? They're all over the place, right? They're running down halls. We had a patient on our floor recently that was it was like a para course. They're like jumping over tables, and we couldn't get them. We had to medicate to calm them down, but we really have to look at what is happening, and getting information when you're at the home is important too, or wherever they are, because it could be that they haven't been on medications, or we have some people that have never been in treatment either, and they need to have that access. Personality disorders, some of the toughest things to deal with, right? I worked in the jail and the prison for a lot of years, and it was like, I got my, you get this barrier there that you don't want to deal with them, and you want to set limits, and this is what it's going to be. Do you guys ever have to deal with this kind of a patient when you're kind of more of a criminal type of a patient? Have you seen that? Yeah, how do you deal with that? Come with me, you're getting on the table, or the gurney?
Again, I think it just depends on the patient.
Mm-hmm.
It's always better to not fight if you don't have to. But sometimes you have to.
Yeah. I think self-mutilation, we've had some people on our floors that when you look medically at what they've done, it's their emotional release. That's how they're dealing with their emotions, so they have to either cut or burn on themselves. We've seen people that look like they've had like they've sat on a grill, and it was actually one stick of metal that they would heat up each time and then touch their leg all the way down, and it's a huge risk. It's emotionally soothing to them because they're getting this release out. They can't deal with life. That's how I cope. And it also looks, some of the damage that they can do with wounds and with burns and things like that, it can really be a lifelong type of thing.
Is self-mutilation a newer thing that we're starting to see? Because 25 years ago, I never saw it. Over the last 10 years, we've started to see a lot more.
Yeah. I've kind of been, I've been in the business 35 years, and I've seen it from the get-go. I think it's probably getting more prevalent. People, what is the one thing that personality disorder people can do is they mimic what other people are doing. They see it, they may mimic it. Are you seeing trends like that with self-mutilation?
Yeah, are you seeing more this year?
Well, I've just been seeing a lot more over the last 10 years as opposed to the last 25.
Right.
So,
And that's something that you don't correct right away. I mean, it takes DBT or dialectical behavioral therapy helps them try and regulate that so that they're not doing the self-mutilation. And they can do anything. I had a patient once where I was in a residential unit, and they called me to this person's room, and she was sitting on the bed, and she was kind of rocking back and forth, and she had ace bandages on her arms. I'm like, what's going on here? Did you fall? Have you been to the doctor? What's going on? She actually, when I took off the bandage, she had gauze bandage under that, and she had put Mr. Muscle oven cleaner on her arms and wrapped it all up. And it was, she had been sitting like that for like 4 hours. So when we did get her to the ER, it wasn't a good thing. But that was her release. That was how she was coping with things in her world. And that's why it's important for you when you're getting out in the community and you're dealing with the mental health patients, you've got to understand where they're coming from. Why are they cutting on themselves? I think it's good to just be proactive and upfront on why they're doing something. Or they could be having a situational stressor that would make them want to cut or burn on themselves. So they're trying to adjust what's happening in their world in an immediate situational stressor. We also have mood disorders. You know,
one more thing. Yeah. I also just think, like, we know now to ask the question, right? Like, we know, instead of maybe 10 years ago, now we know, like, do you have any self-harm? Here are some examples versus before where it was maybe brushed over.
sure.
Mm-hmm. And hidden. A lot of people hide their wounds, and not just mentally, but physically they put them in spots that you can't see. So and we actually get that, and this is something to be aware of, like when you're putting somebody in your ambulance or transporting somehow, is access to things that they can grab. Are you guys aware of that? I'm sure you're hyper-vigilant about it. I know that we are, because in our unit, socks can be an issue, like the patient socks that are about like this big that you wear when you're in the hospital. We've had people actually keep stealing them from other people, and they've made actually a noose and a ligature out of it. So we're always on the alert for in rooms or when they're coming up on their persons. We've had somebody drop meth, crack pipes, everything in their rooms, going, hey, I don't know where I got that because it must have been attached to the sock when I was walking down your hall. You know, it's somebody else's issue. So those are all things that I'm sure that you all have seen and experienced. Are there any patients that you've had difficulties with that you want a little more clarification on, or that you've seen that you're not quite sure what they're exhibiting? You've got these symptoms. Is there anything that you're seeing that is odd to you out in the community, or is it just kind of status quo? Yeah, I get it.
I could spend more time with them. Instead of rushing to get them in the ambulance, you gotta, and having 5 guys in the room with them, have you and your partner in there, whoever they're kind of connecting with, and if you gotta spend 20, 30 minutes, then that's what you have to do so that it's not a fight to get them where they need to go or anything like that, and help them through that situation, because in the long run, that's gonna help them as soon as you get them so you can get them where they need to go.
Absolutely. Do you guys get CPI trained, or do you get any crisis intervention training? I know the police do CERT training. Actually, but some of that's the best. We actually use CPI, crisis prevention. I'll go over the commitment sheets in a second. Crisis prevention intervention your main purpose when you spend 20 minutes or 30 minutes with somebody is to do what? Is to calm them down, find out what's happening, and either transport them or not. And that's building that therapeutic relationship. And that's the crisis prevention intervention. Trauma-informed care is that going back to understanding why they're there and what they may be going through, what things are in their community that is impacting them. How many of you have been in a situation where you're really angry and you're not dealing with that patient right? I have. Do you ever get tapped out? You guys tap out?
As soon as I get spit on.
Yeah, that's it. Yeah, I could, yeah.
Nobody dares do that.
Yeah, part of crisis prevention intervention is when you're trying to de-escalate a situation, a patient may lock onto one person that's coming into the room, and I'm going to be talking to that person. I'm not talking to anybody else, and that's your I guess your check mark to I'm going to start interacting with that person. I've seen it a lot of times where I'm interacting with that person and then they get upset and then I get upset and then you have to just tap out because you're not going to make the situation any better. So self-awareness of how you're feeling and how you're interacting with that person. I've seen mental health workers assault patients as much as patients assaulting staff because they've had their fill. And you need to be very aware of what your limitations are.
Tap out and let the next guy come in.
Yeah.
Good cop, bad cop kind of thing.
Yeah.
Let the next, if you're getting spun up, let the next guy come in and see what he can do.
You know, and that's also part of limit setting and getting things moving too. If you have somebody that's, okay, we've got to get going because we want to get you safe back to the hospital where you're building that more of that therapeutic rapport, you can have a good cop, bad cop situation like that and getting them up and out and trying to set the limit. That's awesome. Does everybody know the commitment sheet? How many of you have, I don't know if EMS, are you guys allowed to do, I know I'm a mental health officer, so I can actually pink sheet somebody and bring them in. Are you, EMS, can you do that? I know police can, right? Police can pink sheet somebody, take them into custody. And so is that taking into custody going to jail? No, it's you guys transporting them to the hospital. What that does is it allows us to hold somebody to figure out what is going on with them. So if you really don't know what's going on with an individual and you're in the community and you don't think they're safe to leave on the street or leave in their home, and an officer is there, you can describe the situation to them, or mental health officer, or a social worker. We can do a pink sheet on them and get them into the hospital. They're held for 24 hours, and then they have to be reevaluated if they are deemed okay to be off of that pink sheet, then we can take them off. And it could be that we're putting them back on medications, or we're giving them medications that help with drugs that they may have been on. How many of you are dealing with meth and opiates and all that stuff now on the streets? We're seeing an astronomical amount. Almost every one of our patients seems to be using at this point. So I'm sure that you're seeing that. So that allows us to keep a patient in a hospital. A blue sheet is a longer stay. It's usually a doctor that has to sign that. It gives us more time in the ER when you drop them off to get the treatment that they need, and maybe even look at if they're refusing meds, do we need to move them to a white sheet? Do they need to be held in a longer time frame against their will? And so blue sheets are usually done in the emergency room. We don't do it on the street. White sheets we do on our unit a lot. That's when somebody is not taking their meds consistently. And how many of these, when you look at taking your meds, how many of you actually take meds that you may be on consistently? I know I don't. When the doctor puts me on some, I'm like, okay, great, let's move to the next thing. They're doing the same thing, except it's affecting their mental illness, and they don't have the insight, we're trying to develop that insight for them to continue to be on their meds. This blue sheet really helps us keep them in there longer. The white sheet, we can actually move to, like, if we get it approved and it goes through a judge and it's with the state and usually the court is up at the U, we can force somebody to take medications against their will. We can actually get people, once they get back out into the community, we can get them back into the hospital because they're not following their treatment guidelines. This is important because they don't want to be in treatment, and it allows us to stabilize them so that they can start developing the insight, okay, maybe I need to be on my meds. Or we've had somebody on our unit for quite a while, and does a medication work for every patient every time? My dad was a physicist, and he always goes, Jim, I don't know why you're in mental health, because, you know, in physics, it's A and B, and then it comes out to C. You know, it's always the same thing. In mental health, medications, your interaction is different for everybody. And that's why we have so many mental health medications. And this allows us, this white sheet allows us to keep somebody that we feel is not safe longer in the hospital, and then move to different stages of that commitment process. If you're involuntarily committed like this, do you think they have any rights? If I take your rights away under a white sheet, does somebody still have rights?
Yeah, probably.
Yeah.
I mean, prisoners still have rights to some degree.
They do, absolutely. So same thing with somebody that's mentally ill, that's a schizophrenic. They have rights just like anybody else. We're trying to allow them to develop that insight, and we may not agree with them not taking meds, but they still have a right not to take meds even under here until they go to a forced medication hearing. So human rights are a big thing in this whole process.
I've got a question online. It says, considering the explanation of the white or pink sheet, what do we do when we have someone in this circumstance on a weekend or a holiday? According to this, it's excluding party time.
So a blue and pink sheet actually lasts the weekend. So I presume that's what they're asking. So if I pink sheet somebody on a Friday and it's a 24-hour hold or a blue sheet, it actually can last the weekend because it's a weekend. And so a lot of times the court examiners and the court will not be working on the weekends. If we move to a white sheet, then we would file the white sheet on Monday when they come in, but the blue sheet or the pink sheet would hold that entire weekend. Does that answer their question? Okay.
They'll check.
All right. Great. This crisis prevention intervention, I think, is really important on our unit. We've had a few people that have been assaulted, their eye damaged, and it goes back to how you're interacting with somebody and keeping that personal space. We get trained in mental health to deal with physical holds or getting away from somebody that may be acting out. So that distance with it's kind of being aware of your surroundings and making sure that you know where everybody is, and never trusting that. We don't trust somebody that's psychotic, because even if I built a therapeutic relationship with somebody, am I going to go chasing them into another room if they're real psychotic? Probably not, because I don't know what's behind that door and I don't know what they're going to do. So I think being aware of that as you're entering buildings and as you're entering homes or even the streets is an important part of that process. So care, demonstrating respect and dignity and empathy. I've really tried to change a philosophy on our unit of treat. HCA has a mission that says treat every patient like they're your family member, and it goes a long way when you're having to set limits. and we got to support people in kind of a non-judgmental way. Even though we see everything and we have our own opinion about it, it's keeping that limit there. Welfare, providing emotional and physical support and acting in that person's best interest. So when you're taking the time to de-escalate over 20 minutes to get them in the ambulance, to get them to the ER, huge. And safety, protecting everybody's rights, and security. What are they going to do afterwards? Are they going to trust you? You ever go out on calls where you've been multiple times to a particular location? Everybody's like, yeah, Jim. Remember, I've got shirts, okay? We see a lot of recidivism in our unit too, and every episode is different or builds on one another. So how you interact with that person each time they come out, or how long they've been in our hospital and the care they get there impacts their next episode. And there will be a next episode. Hopefully not. What do you guys use when you're de-escalating somebody? When you're in your ambulance or when you're on scene, what medications do you use? Is there a typical med regime?
Ketamine's the one that
Ketamine?
they're asking us to use a lot of now.
Ketamine and Versed? Yeah. We use Haldol, Benadryl, and Ativan. That's usually our standard. Seems to calm people down and then puts them to sleep. I know last year when I think it was South Salt Lake Fire Station, we were talking about this, and they were looking at other, I didn't know if they were going to look at changing some of that, but we have a lot of, and Geodone we can use as well. Geodone helps. So if you have access to some of those, I don't know if you've got a wide variety of medications that are in your cases, but these are the typical ones. Haldol, Thorazine are older generation medications. Zyprexa and Risperidol, atypical. So there are newer medications, less side effects that we have with our mental health patients. Benzodiazepines, that's, helps people reduce their anxiety and helps people go to sleep, right? You use Versed. So the other thing to be asking people when you're out on a call is what kind of medication are they on and have they been using? A lot of times we'll have people that come in and they're psychotic and we have no idea what they've been taking, and we try and go guess what pharmacy they've been at, or maybe they could be getting something off the street, I don't know. And so when you're looking at these kind of medications in somebody's med bag, they may have a mental illness if you're not seeing it being really open. We actually increase a lot of our medications as if they don't work, and I don't know if you do that with ketamine. We'll usually start with a B52, 50 of Benadryl, 5 of Haldol, and 2 of Ativan, and we'll double that if it's not working. And do you have to do that a lot when you're you're driving to the ER, or does it pretty fast acting?
The dose they give us for ketamine works pretty good. Versed can be sometimes slower, and you have to use another dose.
Yeah, absolutely. The medication we give actually acts pretty fast. It really starts to sedate the individual. And two, with getting somebody that's psychotic on the Haldol, what is that also doing? That's kind of starting that antipsychotic process. Maybe we can switch to something after they've been in the hospital, but at least it's getting it in there so that when you're taking them off the gurney in room 8 at St. Mark's, hopefully they're not acting out. The Ativans or the benzodiazepines really are more for that anxiety. The person that has been cutting on themselves, those anxiety type of diagnoses are the ones that are prevalent within this medication group. Do you know that ketamine is also used for treatment of depression? Have you guys heard that? There's a couple ways you can do it. It's a nasal inhaler, or at the U, I was up at the U for a while, and we're doing about 0.5 milligrams per kilogram of body weight of ketamine and 500 mils of dextrose, and it helps depression. People actually get out of their cycle of depression. So that's something to keep in mind when somebody may be pulling out ketamine. It may be part of their treatment, not just use it for anxiety. Yeah.
Is anybody really allergic to Haldol, or they just tell you that because they don't want you to give it to them?
What do you think?
I think most of the time they don't want you to give it to them.
I think the one thing, there are some people that can have a reaction to it. Tardive dyskinesia, if they've been on those medications for a long time, you know, got the tongue thrusting or the jaw movement, that can be kind of a permanent thing. People usually say that they're allergic to something when they don't want to take it. That's what I've experienced. I think everybody's different. They may have had a bad reaction to something in the past. You know, maybe they were too sedate. That's why I think it's important to, when you're taking their history, is looking at that medication. Well, what meds have worked, what hasn't worked, and a lot of times we've had patients on our floor say, "I'm allergic to everything that's an antipsychotic." And by the way, who's that person standing over there? Because I don't recognize them, and there's no one standing there. So they're really trying to get out of treatment, or they don't want to take the medications. And have you seen that too? On as you're doing your rounds, like an IOP? Yeah. So questioning, and they may be, they may not be. And then if we look back at their records, I think that's why it's important for us to know where they came from, you know, whether it was West Valley or the streets, or if they've had some community provider that you may hear him say or her say. And you're writing that in your report coming to us, because then we can follow up with that. And we actually made an outreach to pharmacies to see, you know, if somebody came from, I don't know, Sandy, and they're in this one location, we may be calling pharmacies to see if they've had medications there, like CVS. We can call any and then find out what they may have been on, or what they're abusing. Adderall. That's one that people use a ton, and you can start seeing psychosis and some odd behavior out of those type of individuals that we've had on our floor. So this is really this medication thing is huge. And if you're having trouble with ketamine or Versed, talk to them about there's other options as well. So, well, we went over the emergent meds. IMG does a pretty good job. Our hospital needs. Do you ever ask yourself, if you're coming into an ER, what do I need to provide them, or what does the hospital need? Do you ever experience that?
Every call. Yeah.
Every call, right? So when we're looking at it, we're looking at the situation that brought them to the hospital. We're looking at those emergent interventions that you may have had to do on that person, whether it's holding them down, or meds that you may have given them, assaultive behavior, drug or alcohol use. Like I said, we're not a detox unit, but somebody comes on our floor that's been taking opiates for a long time, you know, we're going to be using sea oils and cows and giving them Ativan or clonidine or whatever they may need to get over their withdrawal. And past psychiatric medical history, and then also reflect on your own history with the patients that you're serving, because I remember the first time a couple of years ago when I came onto the unit, and the first patient I saw at the med window, my nurse manager says, "Yeah, this is Jim. He's just new to the unit." He goes, "I know that guy. He fired me 25 years ago." So you build a history with these patients. They are repetitive. You will get to know them, and they will get to know you, and you will see them in the community even when you're not on duty. And So it's looking at your history of interaction. Are there things that we could do better in our ER or our hospitals that could support you guys when somebody's coming in? We're perfect?
This is a safe place, you can speak up.
It's a safe place. Remember, trauma team. It's a shirt, we can trade it out. Just saying.
If you see something, say something.
If you see something, say it. Yeah, so we want to support you as much as you supporting us. I think you guys do a great job. I've seen a lot of people coming in, and I've actually been in the community a lot because I was with teams that would go out when people were acting out in the community, and you guys really do a great job interfacing with the patient. And it's important that we support each other. It's important that you support yourselves, because where have we been in the last year? Not a good place, right? For all of us. And part of that is grieving normalcy.
Wait, can I say something?
Yes.
Before we get back?
Yeah, I'm trying to do a good segue.
I know, I'm sorry.
That was actually really good.
I know, wasn't it?
Yeah. Just so that you guys know what we do before a patient is discharged from the unit, like we try to set them up for as much success as possible. So we make sure they have a psychiatric provider and a mental health therapist and an appointment with their primary care. We do what we can to arrange transportation, to cover med costs. Like we literally do everything we can to set them up for success so that they don't end back up with you or with us.
Yeah, it's that recidivism and doing everything we can. Yeah, I agree. Okay, here. So I really want you guys to be thinking about, when Angie's going through this, what you've experienced, because I know that there's trauma in your circle and what you've been through, and you have to support each other, and you have to support yourself, and you've got to rise above some of the internal guidiness that you have to reach out if you're having an issue. And I think it's important that we bring this up, and Ange does a great job with this grieving normalcy, that we all want to get back to being normal as much as we can.
So I'm Ange. I am one of the social workers that works on the inpatient unit and does outpatient for St. Mark's. I have worked in social work for, oh my gosh, I don't even know, 10, 12 years? I don't know. I got my degree up in Portland and worked there for several years, working specifically with homeless veterans, and worked a lot with on-the-street EMS folks, working with very, very psychotic homeless vets, and now I'm in the inpatient unit. Do you guys have any questions before I dive into this? Okay. So how much time do we have?
We have it scheduled till 1:30.
Okay. You guys do not want to listen to me talk for 45 minutes, so I am going, yes. So I'm going to say this is your time to talk, and I will literally pick on you. So be warned. Also, if you are listening, please chat in, and she will read your chat as well.
And when you guys have questions, if you'll speak up really loud so they can hear on the speaker. WebEx. You're always loud, so we're not worried about you.
You can call mine because it's lipstick.
Okay, there you
Do you guys need a minute to stand up and shake out, or are you good? Okay. So grieving normalcy is kind of the topic for the day, goes over the year. I also just want to put out there that it is by no means, this is not a grief thing. It sounds like there has been a lot of grief in the community, and I definitely want to acknowledge that and put that out there, but this is not what this is going to be. It's more just the adjustment to what life is like now. Okay, so raise your hand, chat in, however you want to do this, if you were ready for a pandemic. You were ready? There's always one in the crowd. Okay. So what about, have you had to adapt your workflow, anything?
Marginally.
Okay. Just a tiny bit? Okay. What about, has the patient care changed?
Bit.
Do you see more or less people?
We saw less for a while, and now it's getting to be more.
Mm-hmm. Have your hours or shifts changed?
No.
Okay. What about, are you picking up more? Are people burning out and maybe you're having to cover more?
Yes.
How many of you were able to take your vacations this year?
I did.
Okay. Are you worried about getting COVID while you're at work?
No, not anymore.
Okay.
We had it.
Yeah.
That's that 14-day vacation, right?
Okay. What about when you go to some of these difficult calls? Are you able to debrief after?
It's been more difficult this year. A lot of your, normal, I guess, ways to debrief have kind of been affected by whatever you are or aren't doing, right? So that's been kind of a pain in the ass, I won't lie, but I've had to find new avenues.
Perfect. What was the way you were debriefing and what are you doing now?
There's no change, it's still out.
Oh, there's a change with that now.
It's just lonelier now, of course.
Okay.
No, I don't know, like, you know, trying to be good, you know, maybe not going out and hitting all the trails when they're busy, like, I like to go ride the bike, things like that. Some of that stuff's a little more complicated, and then not having childcare makes it even that much more complicated, so.
Yeah.
I mean, I don't know, I'm trying to figure out the best I can, but I think we're all in that same boat.
What about debriefing within yourselves? Like if you, so like for example on the unit, when we have a really combative patient, we all go and then we try to debrief for a second afterwards. It does not always happen, we do not always have time, but we try to just check in, be like, are you okay? You got hit really hard in the ribs, do you need to go to the doctor? Like.
Well, the difference is most of us are usually in a station together all the time, so we have more opportunity to do that with each other than maybe you guys do in a hospital.
Does more opportunity mean you're doing it though?
No.
Yeah, there you
The
go.
opportunity's there.
Okay.
Yeah.
How many of you feel comfortable doing it if you need to?
Sure. We do.
Okay.
That's good.
What do you say?
Depends on what's going on.
What if you,
Sometimes you gotta go in and just bust someone's
Make
balls a little
fun of each
bit,
other.
you
A
know?
lot of jokes.
Make a pot of coffee.
yep. So I talk a little bit about with the inpatient folks, like if you are drowning in the ocean and a boat comes up, do you know how to ask for help?
Yeah.
How?
I've called the EAP. I've called my peer support people and said, hey, I'm in a bad way, I need some help.
Awesome. How many others have done that or are willing to do that if needed? Okay. That's perfect. You just totally like skipped over my metaphor. I love it. It makes me happy. So when you think about drowning, right, like people think like, oh, I'm just going to ask for help, but they can't think of how to ask for help, right? So that's perfect. You call the EAP. You maybe turn to a friend. You do these other things. Versus if you're in this, sometimes you don't know the right phrase or what to say, right? So like if you're drowning and a boat shows up, people say, help me, but really is what they need is like throw me a flotation device or help me get on the boat, right? Like some very specific things. So normal, the condition of being normal, the state of being usual, typical, or expected. You guys have talked a little bit about what's normal. How has it changed?
I'll use an example maybe to kick it off. Every time, so in our unit before COVID, people would come up to our unit and they'd come in on the gurney, they'd come into our assessment room, we'd do a skin check, do a nursing assessment, looking at the meds and everything. What is the first thing our staff say now? Are they infected? Are they, you know, it's not just psychosis, it's all the other things that are going on with that individual that are now impacting my staff from kind of completing that job. And so they're really having to look at what they're doing and deal with their paranoia or what they're feeling about the individuals that we're serving. And it's huge because from a year ago to now, completely different. And at home, people at home we're always getting expressed with that. Our staff are more stressed at home, and it's because things have changed. So you have to look at all of those.
So what's the new normal? The mask? Mm-hmm.
I think things have slowed down a lot for us.
Okay.
Usually it's come in, get right to work, get going. Now it's kind of check your temperatures, and it just seems a little slower.
What about cleaning?
Absolutely.
I know that's one thing that, my least favorite thing. It's like, we run a group and then every single thing has to be cleaned and scrubbed, and it's like, I barely have time to eat, let alone clean. All right, so let's talk a little bit about struggling. You guys got the safe version with Jim, now we get to talk about you guys. So, how do you know if a patient is struggling? Okay, so you get called. Okay, you show up and what? How do you know that they're struggling? In whatever capacity.
A lot of history from them or history from the family, loved ones.
Okay, so someone says they're struggling because, okay. Do you guys do any assessments on them?
Look at their appearance, are they disheveled, are they taking care of themselves?
All right.
You go behind closed doors, when you go behind someone's front door, you often see how they're living, and that can be a huge clue, you know, what the environment looks like,
Yep.
you know? Things like that.
Do you do that to each other? Like, what if you show up at work one day and you're just a hot mess? Will someone say that?
Yes.
Why is
Okay,
I've been known to say it.
so you're using those on each other? Okay.
Hey,
Are you,
I've got a comment
Yeah.
from Provo Fire, which is interesting. He just said one of their paramedics made a comment just this morning that Provo has responded to at least one effective or completed suicide every day for the last month, except for 2 days.
huge?
Yeah.
yeah, that's rough. This is why we are talking about this,
Yeah.
how do you handle that?
It could be a suicide. We see a lot of people coming into the ER. We do a huddle every day about what's kind of happening, and that death rate's
Since
going up, and the ICU nurses and
Since
the ER folks, and probably you guys too.
Last month.
You know, oh, that person's, yeah, they died today. You know, it's like we're getting accustomed to such a high degree of trauma. It's huge. We're seeing that constantly.
Traumatic injury.
So what do? Do you show up?
The biggest thing you can do when someone's struggling, you know, I'm not clinically trained, I don't know what to do, but I think being there helps. Trying to be there, they might not want you.
For your patients and for your peers?
Yes, I'd say more importantly for your peers.
Okay. What about when you have something like that, or another challenging call that you respond to? What do you do? Does that impact you at all?
You know, over the last handful of years, we've, at least in the fire community, and I think probably along the same lines with PD and the military, we've actually really started to recognize the importance of watching out for each other.
Mm-hmm.
So, you know, we have the development of peer support groups. And the biggest problem, I think, is the lack of education for mental awareness and acuity in our field of service, right? And actually recognizing those things. But as people start to learn more about mental health and the effects of, you know, some of these stressors that it has on us, I think people are becoming more aware, more keen to individual subtleties that might take place. And so I think that we're recognizing them earlier, and I think that we're probably intervening a little bit earlier, although we just don't have a lot of education in mental health, right? Ask us about cardiology. I think most of us do pretty well, right?
What about if you do go to a mental health provider, let's say, how many of you feel like you spend half the time explaining your job? I would say that's probably the biggest barrier that I see is you go, or military or police or someone, and you spend half the time just explaining what your job is and why the situation even got there before you can even process it.
That's why we typically only like to talk to each other, I'll be honest. I know when I went to counseling, I didn't really appreciate getting around some of that stuff, because it was like, dude, I don't really, I don't want to teach you my job, I just want to.
Right, you're not here to educate us.
Right, and I think that's hard, because I think our professions are so kind of unique and out there, and the culture is incredibly different than any other 9-to-5 life.
Yes,
So
I would 100% agree, and I know they are trying to work on that. I know there's a big training that happens every year that, I don't know if you guys go to in March. I can't think of who puts that on right now, but it obviously did not happen this year. But that are trying to break through some of those barriers. But I think that for me, is a big barrier as well, right? Like, if you come and see, if I was your therapist, like, I would be like, okay, how much of this do I need backstory for, which is not fair to you. Did you have?
I think, too, when you talk about kind of being in your clique and talking about what's happening in there, that's important. I also want to stress that it's important, like in our hospital, when people talk about the mental health unit, they're like, I ain't going to that unit. No, I'd rather go work cardiac. I'd rather go work on the floor. But do you think that you see just cardiac on the medical floors? You get mental health is across everything. And we do BERT calls. It's a code gray in our hospital where if there's somebody acting out, we have to go to that unit. Everybody goes, everybody responds, and we de-escalate that situation. And then the behavioral health emergency response team stays to kind of interact. We've educated other people that don't get our area. So don't think you can't, I know that you've got your clip, but if there's ways of getting people to understand where you're coming from, that's an important thing, because we've done it in our hospital, and now they see us come and they're like, oh, that's great, or gosh, I really understand where you're coming from with that guy that's psychotic, and now they're ripping out their IVs. Now we know what we need to do because you've educated us. So I think it's important definitely to talk in your clique. It's important to get it out there too, because we need to know what you guys go through. People need to understand that. If you can develop a good, I guess, a therapeutic relationship with the people.
And there are providers that do specialize.
I think it is really good for us, in our clique, if that's what you want to call it, to talk to each other, because we can talk in certain ways that everybody understands, and you're able to have that conversation. But from what I've learned also, you need to go also see that professional, because they also ask certain questions or in certain ways can open a door for this or for that and help in different ways. And so yes, it is very therapeutic, and it helps a ton as a crew and as as your peers to talk about this stuff, but it also does help to seek that other professional help too, to help kind of open some of that up, and there also can help you learn how to cope and deal and come up with those ways to help you get through some of that stuff also.
It's not just the schizophrenic that needs to develop insight. You have to develop insight on yourself to change things that you could be going through. Absolutely.
And if the therapist that you're seeing you don't click with, find another one. You do not have to stay with them. There is no hurt feelings. You get to pick as many people as you want. So how do you know when you're struggling? What does it look like? Minister.
I think our families probably get the worst end of it when we're having, when we're going through stressful times at work. I think our families get the brunt. And
How so?
mine does. When my kids were younger, I just was less patient with them. And I didn't even realize that's what was causing it until I was a little bit older and my kids were growing up older. And then I look back and I thought, yeah, that's what caused that, you know, was I was up on a really bad traffic accident, you know, that morning before I went home or whatever. And so I think it's good to know that so that you can be more careful the next time you have a traumatic call or a stressful situation, that you go home and you're more cognizant. I need to be more patient than normal because I'm not normal.
Which is hard.
It is hard.
Yeah.
Especially when you have two boys that fight all the time. They're old now, they don't, but they did when they were young.
You what?
I was just gonna add.
Oh, please add.
Brought up a picture. Well, I think that if you actually talk to people, and that's one thing that I do is I listen to what they're saying. And when they start talking about, oh, I'm just tired all the time, or you hear about them drinking more than they would in the past, or they're not interested in anything anymore, or they didn't have fun on family vacation, you start looking at all of these things, and you start to realize that maybe that individual will have a difficult time.
Right, especially if it's someone that you know, like, oh, I love going to do this, and then it's like, they did it, and they're like, man, it was fine. That's key. That's huge. And that's usually going to be the first sign, right? If someone's going to be like, wait, what?
How many of you like your job? That could be one area that goes too. You're like, gosh, that was something I really like going to, and I'm starting to separate myself from it.
How many of you feel valued at your job?
Code pink, L&D Tamper. Code pink, L&D Tamper. Code pink, L&D Tamper.
What did she say?
Little pink, sorry.
You could hear it.
Triple pink.
I'm still hearing it.
That's usually when a baby gets taken, right? Come pink.
Yeah.
It's the tamper thing got half the door probably.
Usually
It's a dad taking a baby out to show somebody and.
They also fall off all the time. Does anyone recognize any of these in themselves?
I mean, the design's a lot nicer than my house, but.
The color.
I like this because, like, some of the ones, like, you can't stop scrolling through social media. Like, I feel like that is a great distraction.
Code pink, all clear. Code pink, all clear. Code pink, all clear.
It's all clear.
Very.
Relax.
So I often make our patients make one of these for themselves and hang it up somewhere where their family can see it, or someone can see it, so they know, all right, these are some signs that maybe I'm not doing okay.
It's amazing because she's kind of done this in groups that we have in our IOP program, and it really kind of forces you to look at what you're experiencing when things are going wrong. You really have to look at that insight that you have as those signs.
I'm going to skip a little bit because I want to get to the end. So, well, I have like a gazillion slides, and I think that the end is the best part because it gives us solutions, and I want to make sure we get there. So, essentially, the flow is thinking about what makes you happy. So we talk a lot about what signs you're struggling, what are signs that you're doing really well. And then talking a lot about self-care. So what do you do for self-care?
Self-mutilation.
There you go.
A lot of people do.
True, that anxiety goes.
So this is what I think of when people are like, you need more self-care. Probably my least favorite thing as a therapist to hear. It brings out that like rage and frustration. Like, right? They talk about like, go get a massage or take a day and go do this. And it's just like, is that realistic? So this slide essentially just says no, it's not. Self-care, still being burnt out and exhausted, it's likely you're going to get advice to do more self-care, right? So take yourself out for lunch, get a manicure, do some yoga. It's great, but it's not self-care. Essentially, this slide is saying it's adding something else to your to-do list that may add more stress. So this is what I like to focus on when we think about self-care. It doesn't have to be massages and fancy lunch outs.
Well, it's funny, because, you know, spending time alone up there, but if you go back to a couple slides, you have spending time alone. So it could be good and bad.
It goes back to why you're spending time alone.
Yeah.
And spending time alone is not for everyone, right? That's not self-care for everyone.
Well, doesn't self-care also have to be purpose-driven? In the sense that if you're not addressing an issue, or you're not, you know, if it's an avoidance tactic, it's not self-care, right? And that's what fancy lunch out is, right? Whereas taking a walk and grabbing a cup of coffee and talking to whoever it is you talk to, that's more purpose-driven, right? You're addressing the problem versus avoiding it.
Yeah, I mean, it can be. So this is like when people talk about sleeping or screen time or reading, like some people feel like reading is not the same as relaxing. But I think about, like, if I was told to read at school, that did not feel relaxing. But if I just get to choose what I want to read and have some downtime and read for leisure, that feels relaxing, right? So it's just like the alone time. You have to find things that work for you that don't feel like a chore or a distraction. So self-care is essentially making the decision, right? Do I spend the time alone? Do I go do something else? So I just want to really focus on, I don't know how to use this, but this slide. It means that you have options. You get choices. You get to say yes, you get to say no, and that you get to choose, right? So self-care essentially is boundary setting. How many of you are good at setting boundaries? How many of you are better at setting boundaries at work than at home?
How many don't know?
Okay. So this is where the three choices come in. So you have the option, right? So if I say, hey, get up and do 15 jumping jacks right now, you can then be like, yeah, I'm not doing that. Or you can get up and do it. Or you can say, what if I do 2? Right? You get that choice. So being part of that is learning that people are going to be mad. People don't like it when you say no. How many people like being said no? If
My whole family loved it.
Your family loved it?
Right now, they really love when I say no. Super great. Well.
So setting boundaries does not always feel great, but it's sometimes the only act of self-care that you can do. I'm not going to read all of this because I just want to read this one on the far side that says setting boundaries is an act of love towards yourself and an act of respect towards others. Skip over some of these. All right, so let's go back to the same questions from the very beginning, but now let's think about your home life. How many of you are ready for a pandemic? Okay. How many of you had to give something up this year? What about something small, something big, anything? How many of you had to give up a family gathering of some sort? What about like a date night? Or dropping the kids off at school?
Or freedom of not wearing a mask.
Enjoying the ease of just being able to run to the grocery store for one thing. How many of you have had to change your daily routine not at work? I know that we're far enough into this, it maybe doesn't feel like it has been a change anymore, but think back to the beginning. How many of you struggled with some of these things at the beginning? Or if you look ahead to like the December holidays, like how many of you were worried about this for that? So this is where we're going to get into the grief talk. So grief, like I said earlier, is not always just about someone who's passed, right? So it's the deep and poignant distress caused by, or as if by bereavement, the suffering or distress over affliction or loss. Sharp sorrow, painful regret. So this pandemic, essentially this year, with all of its components, it's not just the pandemic, but the election and the protests and all of these other things that have come up, right? It's not just one thing, but it's a whole bunch of things. So we know that in theory this is temporary, right? We have vaccines on the horizon. Hopefully that will be able to get things back to whatever normal is. And we realize that things are going to be different, but we're grieving on a micro and a macro level, right? Like it's not just affecting you at home, but it's also affecting your work and your everything. So how we are impacted is going to be different, right? Everyone is taking this and dealing with it differently. And we're going to experience different levels of loss. So these are some different types of grief. So do you guys just each want to read one? I'm going to have you start at the top.
Non-death loss. A person can grieve the loss of anything significant to their physical, psychological, spiritual, and interpersonal lives.
Perfect.
Secondary loss. There is a ripple effect and subsequent loss.
Ambiguous loss. When something or someone profoundly changes or disappears, these losses are opening.
Cumulative loss. The experience of suffering a new loss before you have the chance to grieve a first.
Dude, that is.
I know, you gotta read it.
That makes me feel all warm and going.
No, stop it. Stop. Now I'm feeling bashful. Stop.
I like it.
Non-finite struggle with the push and pull of trying to achieve their dreams, but continually finding that life falls short of their expectations.
Anticipatory. That feeling we get about what the future holds when we're uncertain.
Does anyone identify with any of these? Anyone want to tell me about how they identify with any of these?
I'm having anticipatory loss because our department is shifting our shift, and I have to go to B shift, and I'm not super happy about it. And kind of like my old crew. I mean, they weren't great, but they were okay. So I'd like to be back with them, but now I have to go.
Okay.
Throw that out there.
So what can we do with it? So I don't know how many of you are familiar with the stages of grief. But essentially it's like, well, I'll read through it. So they've added a stage of grief. So understanding the stages of grief is a start, but whenever I talk about, so David Kessler is a grief specialist. Talk about the stages of grief, I have to remind people that the stages aren't linear and they may not happen in this order. It's not a map, but it provides some scaffolding to hold on to. So there's denial, which we say a lot of. So again, this was put out pretty early on in the pandemic. So there's denial, which we say early on, the virus won't affect us. Then there's anger, you're making me stay at home and taking away my activities. There's bargaining, okay, if I socially distance for 2 weeks, everything will be better. There's sadness, I know that this will end. And there's finally acceptance. This is happening, I have to figure out how to proceed. So acceptance, as you imagine, is where the power lies. We find control in acceptance. I wash my hands, I keep a safe distance, I can learn how to work virtually, or not. And then it talks a lot about compassion and self-compassion, which I'm not going to go a ton into, but I highly recommend looking up Kristen Ness. She's a compassion expert. So she talks about these components of self-compassion, which I think are really important as you move forward, but I'm not going to spend a ton of time there because I want to come up with actual solutions. All right, where did we leave off in reading? I think with you. Will you read this?
Yeah. The best thing about your life is that it's in a constant state of design. That means you have at all times the power to redesign it, make moves, allow shifts, smile more, do less, say no, say yes. Just remember, when it comes to your life, you are not just the artist, but the masterpiece as well.
I think we sometimes forget that, right? So now what? What do we do now?
Live.
Do you want to read the first three?
Or
Wait for the future. Yeah, practice mindfulness meditation. Don't self-medicate at the end of a long day.
Wait till the,
Good thing we don't have an end of the day.
Do you want to read the next couple?
Get creative with important life events. Choose to be optimistic about the future. Establish a support system, peer support. Don't forget to feel the moment. Reduce your exposure. What's that supposed to be? Exposure?
Oh, yeah, sorry.
Okay. Reduce your exposure to small material.
What?
Reduce health before it's a crisis.
Questions on these?
you're supposed to be request help, right? The
What?
last one got back with it. To be request, not reduce.
I always reduce my help.
Yeah, winning.
Do you see the attention to detail that you guys put in? That's awesome. Now you just gotta put it in your lives like that.
So, one of the things they find out is that our brain needs to understand that things are happening in order to move forward, right? So, these like big life events, so birthdays, end of school, beginning of school, holidays. So my little sister turned 30 this year. We had a giant trip planned to Boston. We were going to go to the baseball games. It was going to be awesome. COVID happened. Obviously, that did not happen. So we had to find a way to virtually celebrate her 30th birthday. It was the most disappointing day I think she has experienced in a long time, but our brain needed a way to recognize this life event in order to move forward, right? So whether it's kids' birthdays, big vacations, the holidays, my parents are old. I did not spend Thanksgiving with them. We took advantage of the free Zoom, right? Like we had super awkward virtual Thanksgiving, but we were able to celebrate in our own little way. So getting creative with these life events is going to be key. You've been doing it for months. I anticipate that that will continue on. I also anticipate you guys will probably have first access to the vaccine. You don't know that for sure, but hopefully knowing that there is some version of an end will help. But what do you do in the meantime? How do you incorporate these into your life in the meantime? What does that look like?
I think a big one for fire guys is don't forget to feel it. We're already bad about this on calls, especially if you've been doing this job for a minute.
Is that helpful? Okay. Do you know what to do when you do feel it?
Sometimes.
Literally a cheat sheet.
And there's also a comment online that says, be the support you wish you had when you need it the most. Empathy goes a long way.
It's true.
When you're looking at your colleagues right now, what do you see? Their eyes, right? Well, you know, I know you've known them a long time, but I want you to think about their eyes. You know, I see it. Look at this though. When we're dealing with mental health, your face is all your emotions come out on that. It could be anger, it could be sadness, it could be happiness, it could be anything. All of this, when we're trying to diagnose and we're trying to see what's going on behind this, has been a huge impact for us in the mental health system. What happens when you're sitting there and you're psychotic and you see all these guys coming up with black and blue masks? Hey, how's it going, man? What do you need? And that communication is not there anymore. That's been a huge thing for us in dealing with people's emotions and your own, because you can hide stuff behind a mask too with what somebody's going through. So it's important that looking at that for yourself and your colleague.
Are you the only one who hasn't read Do you want to read the first three?
Just kidding, I was just practicing.
I love it. In that case, you want me to read two.
Great.
Be
Able to name your emotions and give yourself time to feel them. Connect, phone a friend, family member, emotional support line, etc. Be upfront with your own expectations and acknowledge that what may or may not be realistic. Write it down if needed, revisit, and check in with yourself.
So know that you are not responsible for this and allow yourself to be mad, sad, lonely, etc. if needed. Write something fantastic about yourself and hang it on a wall where you can see it daily. And just be kind to yourself. We're all learning and adapting. I just want to go back to the naming and kind of feeling your emotions. If you hate that and you need to like process through it, set a timer. Set a timer for a minute, for 30 seconds, for 5 minutes, whatever it is, and just let yourself go down that little rabbit hole or whatever it is for that time. And then just know at the end of that, you can bottle it back up or hide it or whatever you want to do, but you've got to let yourself go through a little bit of that feeling, or it's just going to keep bottling and bottling and bottling, and then you're going to explode. So the last few minutes, I want to think of some ways. So at the very beginning, you talked about getting out on trails.
Yeah, going out riding.
So what else do you guys do? I want each of you to tell me one thing that you do.
Martial arts.
Okay? I don't know who that was. Okay? Let's go with you.
I like mountain biking.
Okay? Horses?
It's like something we do to cope with our stress and everything. Journal writing.
Okay?
I got a puppy. Remember that? She's awesome.
Big difference.
Good mom.
Okay.
I like camping and hot rods.
Okay.
Archery.
Okay.
Staying outdoors.
Awesome. And how often are you able to do these things?
Not enough.
So going back to that, saying no and setting some boundaries maybe, utilizing some of that vacation time to do things like going to Moab or going somewhere that you feel comfortable doing, or even just taking the time off to just relax. I know I'm on day like 12 or something like that with the holiday, and I like am counting down the day that I don't have to wake up at some ungodly hour to be at work. And I know for me, sleep is a big thing. And there is not nearly enough hours in the day to get as much as I would like. So, how many of you are sleeping well? How many of you get enough to eat during the day?
In this group.
Okay. I mean, some of these basic self-care things are going to be key, right? I know when we get super busy on the unit, it can be late in the day and I'm like dying and I realize, oh, it's like 3 o'clock and I haven't eaten or peed or done any of these basic needs because we've been so slammed. And it's so easy to tell people what to do and so hard to follow it. So anytime you think that you may need a little bit of something, talk to yourself like you would tell your friend or your partner or your kids, or, right? Like, give yourself the pep talk, like they said earlier. Give yourself a pep talk that you wish someone would be giving you. And check in on your peers. Any other thoughts, feelings, emotional outbursts?
Emotional outbursts. Do we have any questions online? You can star 6 to unmute yourself. Any questions? That's so true, right? How do I do that?
One thing that I like seeing too, because you guys have a very similar sense of humor to me and what happens on our unit, and that definitely helps alleviate stress. Can it also hide stuff too?
Sure.
Exactly, so never, right, no, so be aware of that too. I mean, I like the humor, cause believe me, it's fun.
Same.
I get it.
Ron Williams.
Yeah. Be aware of that.
That would be it.
Until it is, yeah.
All right.
That was quiet the whole meeting.
Thank you.
Thank
All right,
you.
all right, you guys, we'll go ahead and end today. Thank you so much for joining us online, and big thank you to Ann and to Jim.
Thank you,
And, anyway, stay safe and stay healthy and enjoy your holidays. Take care.
Thank you, we will.
Is that a bit noisy?